Okay, great. Hi. Good to see some of you all who I've seen before. So the conversation now is going to actually be an extension of what you just heard around particularly innovation and leading change. A little bit more of the leading change part specific to an initiative we did here at FirstHealth starting 18 months ago, about maybe 2 years ago now, Amy. And so what we want to do is talk to you about the principles that we laid out even before we started the initiative. How we thought about the change, how we organized the change, how we led the change, and then some of the outcomes. And share with you some of the insights we learned from patients that maybe you probably think about in your own practice, but some things that we've been able to institutionalize through data and some qualitative analysis. So from a principle point of view, we set out from the beginning to say, yes, we all care about the people that we serve, but we wanted to think about how we could create a wraparound service, essentially, in summary, to you as the clinicians to create a care system around you to help you do the things that you do wonderfully, and that's care for patients. We know, and the reason why I say that wraparound service, because we know that a lot of the care that's required for people are outside of the medical system, right? Social things. For 30 years, there's been plenty of research that talks about our outcomes from a quality of life, length of life, 10 to 20% somewhere about medical care, direct medical care. And a lot of the other outcomes around well-being, quality of life, length of life are about our social environment, our economic environment. And so what we wanted to do is to say, to create the best care system possible, to do it in partnership with providers, let's create a wraparound service that could help providers be the best that they can be, and of course help patients and people live their optimal life and help them thrive, which is all of our goal, correct? So what we did, we used these principles of focus on the person, not the patient, make sure that we build a care system, skills of our team members and some tools that could help us understand what matters to them, not just what's the matter with them. And then also, when we do that, to make sure that we are working towards creating a care system that was a wraparound service to you, that was both a health and social care system. And so we set out to do that, which perhaps we'd call it a pilot, a small test of change in Richmond County with a very small team that could help us figure out how do we do it in our context, our environment. So one of the things that the UNC team talked about that'll be really important as we go through this is they talked about transformation, innovation, transformation. There are different types of innovation. Ultimately, we think this is pretty much turning into and can turn into a transformation, perhaps not there yet, building towards it. But one of the things that you'll learn is, here as in Physician Leadership Academy, is that the approach that we realized it was not a technical problem we were trying to solve, right? You remember that slide, technical versus adaptive? It was an adaptive problem where the solution wasn't known. You had to work with the providers and the inpatient, the outpatient. You had to work with the social care system. You had to find the right mindset of the team members to do this work. It was adaptive, where we had to, over time, put in a learning system to adapt to get to some of the results that we see today. So what is the why? I talked a little bit about the why, about how part of this, the challenge of the care system, and the challenge of us trying to optimize people's lives, help them thrive as much as possible, that a lot of times, as we know, zip code determines more of our health and outcomes than just our genetic code or the illnesses that we face when we come into the medical environment. And so because of that, again, we wanted to create this wraparound service to help us create a care system, the entire goal, a care system that put the clinicians in the center, but help them achieve success in optimizing outcomes for patients by providing some tools, patient-centric tools, and the care team members to help patients thrive, and of course, create the care system and help physicians thrive. And so the second point here is actually a quote from Deming. If you all know Deming and really launched the whole Lean initiative across many industries, but that every system is perfectly designed to get the results that it gets. And so historically, and sometimes, a lot of times a patient comes in, they get medical care, but they go out and their life or their well-being necessarily isn't necessarily optimized because they have all these other social needs. Right? And so what we try to do is to make sure that we can provide the best medical care as you all are doing now. It's a fantastic medical system, but extend this system to get results that also help people thrive from a social and medical point of view. That we can help people stay out of the hospital. We can help people stay out of the ED. when we can, right, for non-emergency issues, that we can truly make sure that everyone who lives in the First Health service areas has the best opportunity to thrive. That's the goal. And so we want to create that system. That's the results that we want to get. But just through medical care, we can't do that, right? We know the restrictions on just being a medical system. And so we also wanted to make sure that as physicians, we know this, and you see it. You can all, I'm sure, think of patients who, perhaps you want to use this word or phrase, a social train wreck, and you're doing everything you can, but they're not maybe compliant, or they're not able to do the things that you would hope for them to do. We wanted to create, again, a wraparound service that could help them achieve those things that maybe they could do outside of their clinical issues so they could optimize well-being and health. And so a lot of times, because the wraparound service wasn't there before, we heard this from clinicians, sometimes I just avoid asking that or diving into those details because I can't do anything about it, right? Even though I know that might help the well-being, it might help them be quote-unquote compliant with the medical issue. They have to address these social issues first before they can address their medical sometimes. We wanted to provide that help and make sure that we created a care system, and we'll get into how we did technology, the patient-centric tools, the care team, to help you all not be afraid to ask those questions. And so that we could, then you had someone to refer to help you. You didn't have to deal with it, but you weren't afraid to ask the questions so you could actually direct them to a service that could help them. So that was a primary why. What was another more local why is, you all may recall that First Health bought, what was the name of the hospital? Sandhills. And so 4 years ago, when Amy and I were introduced and the rest of the team, the leadership team, we talked about getting to know that community better and really building a relationship with that community. There was some distrust, right? It used to be competition. Richmond Hospital was right down the street, literally like a turn around the street to Sandhills. And there was a lot of distrust from some of those providers who came into the First Health system and from the community members on First Health. There was a lot of competition in that area. And so we wanted to engage the community. And we started off with engaging citizens, not just the medical providers, but early days it was doing some work in a community down there and really understanding what their needs and preferences are, goals, et cetera. And then we started to engage the providers to really show them that we could work in partnership with them through building this wraparound service. And to say, we're here for you, we're here with you. And interesting, when we first did this sort of goes to leadership, right, in your role as leaders and how to engage people. Like, we weren't kicked out, but we weren't welcome. And so, but what's interesting is that, and it wasn't about us and our service, it was truly about the animosity towards First Health. It was, you represent First Health, we don't want you here. We know what's best for our community, we don't need your help. And so, but what happens now is because we continue to engage those providers and show that we could do work for them, some of those providers down there now are actually our highest referring providers. And it was simply just by always being there, just by responding to them, just by taking little small steps to prove that we're there for you, we're there for your patients, and we want to work in partnership with you. So that was one local why. Plus, again, if we are trying to get the results that we talked about from optimize well-being, optimize the opportunity for people to thrive in their service areas, we needed to better understand the concerns and needs of patients, of residents in those communities that we're serving. And so we're going to talk about how we built tools specifically designed to do that. And then, again, create a medical/health and social care system for those who are most vulnerable. The model is for anyone. But in particular, this is the majority of the patients that we partner with are those who are vulnerable in social care issues, economic, et cetera. So we wanted to make sure that particularly for those patients who are perhaps more of a challenge through social and economic issues, that we had that strong wraparound service that if you needed someone, you could refer them to this team and know that they were going to contact this patient, do what they could, partner with social care providers, keep you informed in what's going on, and do their best to be a partner with you to help them through their issue. So that medical and social care system is a key goal, and is a key outcome. So, but out of the gate, to do that, right, to understand the needs and preferences and goals of patients, we had to create some new tools. So right out of the gate, and we'll show you the tool in a second, we said, well, how are we going to learn in a simple way possible, not some lengthy 4 or 5 page questionnaire, but how are we just going to get to some core points about what matters to people that we serve? So we created something we call an About Me card. And of course, that was very intentional. It's a bit of marketing, but it's intentional that we truly care about you. So we want you to tell you about me, or the patient. And we made it very simple, and we'll show you that in a second. But we also said that's not enough. So what if someone tells us that they have a social need of any kind, economic, housing, safety? Well, who cares if you create the card? Because if you can't do anything about it, it doesn't matter. So we created then, well, what are we going to do? What's the sort of decision tree for us, right? And that means that it's not just about working with you if it's a medical issue, but we had to go out and make sure that we talked to all of our social care partners, said this is what we're doing, and we were very clear on how we would also do referrals outside of First Health with social care partners, right? And so we built a system, a decision system within the team. But before that, what we also did is we said, well, some patients are going to come in, because we're asking general social questions, they might come in and say, I have 5 things I'm really worried about, along economic lines, for example. I might lose my utilities. I don't have a heater. I have mold in my home. Or I might lose my housing, et cetera. We also made it very clear that we had to work with the patients to set clear decisions on what we're going to work on with them in partnership. So we created what we called a decision card. And we said, okay, great. You have 5 things. And what's most important to you? What's most emergent for you? And we always say, what are we going to do together, right? Not assume that their responsibility to fix everything, but what are we going to do together in the next month, the one thing? And so this decision card, we would literally fill it out with the patient, and we would say, okay, we're going to do this, and then when are we going to talk again, and how are we going to contact you? That's it, 3 things. Like, very clear, very concise, and sometimes patients, you have to do 3 or 4 things because there's that much of an issue, but we would always try to get there. So it's really crisp. And we had to do that for a couple of reasons. One is because we have a lot of patients in our queue. We had essentially 2 people on the team. And plus, we weren't trying to take on fixing all the issues of the county. People have to take agency, right, as you know, and addressing their issues. We were trying to be a partner with them in building that self-efficacy. So we did that. I talked about the co-production model. I talked about building the social care system. One of the things that we did early on to make sure that we could succeed with a team of care partners is we said, we're going to create an MOU, Memorandum of Understanding, with our social care partners. So DSS, a housing agency in the area. Transportation. And it was really informal. It wasn't a legal thing. We just literally invited them to our space down in Richmond County and said, we'd love to work with you in this way. We know each other. Right now, somebody makes a phone call, we do this thing or that thing. We don't have shared goals. It's not really clear on who's doing what, who's responsible. We don't really hold each other accountable. And so with that MOU, we literally created, I think it was a 2-page paper. We said, this is what we'd like to do together. Do we agree these are our goals? Which are the goals that we just talked about, creating a health and social care system that can optimize well-being, right? And we would meet with them monthly until COVID, and we would talk about what's working well. What is it? Is this MOU working? What data do you have to share? And so we set the boundaries, I guess you could say, with our social care partners to make sure that they understood that we wanted to work with them to achieve these goals. If we weren't just a medical system, that we were their partner as well. And so what we did to get started is we did those things I just mentioned. We built those operational processes and methods and tools. But the one thing given this is a Physician Leadership Academy, let's talk about is we also had to be really thoughtful on who we selected to do this work, right? Mindset. There's one thing that the UNC team said that should probably be touched on is that changing structures is not going to solve the problem by itself. you have to, and they use this, you have to change the mindset, right? Of the structure itself is one thing, but the mindset and the culture isn't changing, isn't shifting. The best structure in the world and the best process is not going to get you to where you hope to go. And so for us, we also knew we weren't trying to change the mindset broadly early on. We were trying to prove that this could work. So we made sure that we selected the one person in Richmond County who had the mindset that we believe we needed to succeed. And then we cultivated that person into a leader, building processes, building tools, things that she hadn't done before, which gaining skills is a lot easier than changing attitude. And so we really picked that person first to make sure that this is going to be hard, right? It's adaptive. There's not a solution to doing this. We have ideas, right? We picked, I think maybe it's on the next page, but one of the things I've been lucky in that when I started at Dartmouth, it was right after the ACO rollout, and part of my job was working with physicians and ACOs, or people who were thinking about being ACOs across the country, and had hundreds and hundreds of conversations of how do you lead change? What do you do? How might we do this, right? ACOs are principals, but they're still not that successful, right? 10 years later. But it was always, how do we make this happen? It was an adaptive mindset. And so we also learned, how do you build registry-based environments for quality improvement? How do you develop and implement patient-centric tools? We brought all those ideas into our mix. But one of the things that we've also learned from that experience, which is really important in this context, and I think UNC also touched on it, is you could go and you could talk to any system in the country or the world, because some of the work I've brought in is from Sweden and stuff we've done in Sweden and other countries, and say, wow, they really knocked it out of the park. But one of the things is really clear is you cannot take a process or a technology and just say, here you go, and you should succeed, right? So we just took principles of what other people have been doing around the world and say, how are we going to adapt it to our environment? And be really clear that then once you set that mindset in place, you create a space. This is the other thing that UNC didn't talk about, but the principle of change leadership is then you have to allow the space for failure. They did talk about the failure. But you have to allow the space for figuring it out. You have to allow, okay, that didn't work so well, that's okay. But we're going to learn from it and then do better and move forward. And so we built the foundational processes, we built the mindset, we built these tools. We also, on the PCP side, tried to select PCPs we thought would be open to working with us. Not really asking them to change too much, but at least just work with us. Hand out this About Me card that we'll show you in a second. Have a conversation with the patient about it. Just try. We didn't tell them what to say. We didn't tell them what to ask. We just said, you know what? You're going to figure this out. You know the patient's best. Here's a tool that can open up a conversation. And if you find something from this card and from the conversation you don't know anything about, here's the email. Here's the number. They can text us, send us a message in Epic, whatever. All good. We'll bring you back data, in a month or two, tell you what we're learning about your patients. From when they complete the About Me card, we'll talk about how it's going. So really adaptive, really open. Didn't ask physicians to follow protocol. We were trying to establish a protocol together. So, and then because word started to get around, we were in Richmond County, we talked to the president of the hospital down there, John Jackson. He expressed interest in allowing it in the hospital. So then we said, okay, great. Same approach. Let's be adaptive. Here's what it is. You as nurses, you as clinicians, take the idea, how would we do this? And they said, a plan in place. And we followed it, and we responded to them. And still, pre-COVID, every patient essentially, minus if they had an emergency issue or had a mental issue or something, is getting this card in the inpatient setting in Richmond County. And then the nurses would send us a Cortex message to say, this patient needs your help. And if we're available right then, we'll go up because the team is down there next to the hospital in what we've called the care suite. They'll go up and talk to the patient. What are your primary needs? We know from research, and you all know as well, that was so important because we know that getting those patients and building a relationship with them before they go home, so they know you, they see your face when you call them or do whatever else and talk to them about the needs that they've expressed, they already know them. So we made a really big effort to try to get the patients while they're in the hospital before they went home, so they would answer our calls, would respond to us when we tried to reach out to them after they were discharged. So then after that, we got all that work, it's going, and obviously this is all pre-COVID, by the way, so we're trying to get going again. We shared our work with other PCPs and said, again, not a requirement, this is what's going on, this is how we're working, and would you join us? And providers say yeah. Some providers would adopt it more quickly than others, but we learned a lot from that experience, right? On how do you engage providers, how do different practices work? We try to allow as much flexibility as possible. Again, this adaptive, trying to figure out, again, not trying to say do all this, everybody has to do this, but how would you do it? Because we can always learn from each other's innovative ideas. From that, we've now got into, and we'll talk about this next steps, but all of that learning led to the fact that now we have the About Me card, which I'll show you in a second, actually in Epic. That we didn't start off with, one of the things that I didn't mention, but we started off with this card, again, being very adaptive. We didn't create technology first. We said, in order to learn, in order to be adaptive, in order to figure out how do we do this in practice, we actually started with a paper card. And so that paper card is literally an index card that's two-sided, and this is the front side. And because this is an innovation, again, one thing else we learn about innovation and deploying innovations is don't start with the technology often. I mean, sometimes like the messaging you showed that from UNC, it's great, it's fantastic, but when you're really trying to shift culture, for example, when you're trying to new way a process, sometimes starting with the technology and doing all that investment up front before you've really figured out how to make something work, again, process-wise, culture-wise, and technically, you can get bogged down in technology, try to implement it, and you figure out, well, I messed all this up, I spent all this money. So what we did is we started with something very simple, and we said, to all the PCPs that we talked to, we had this idea, this is what we're trying to do, the wraparound service. All we're asking you to do is hand out this card to your patients before they come back and see you. And this is in the PCP. On the inpatient side, patients got this card when they were in bed. I said, super simple. And we don't want people to read a bunch of questions, again, not 4 pages, because all we're trying to do is understand people's core concerns and needs so that we can identify how we can provide a wraparound service to the medical team, and that then we can have conversations with patients that get to the deeper layer, right? It's very intentional in that we want to have conversations that get to the deeper layer, not have them complete a really lengthy question that gives us the idea that we might actually know the deeper layer, which still you don't. And so we just ask questions that give us their points about anxiety, again, losing utilities, et cetera. But there are a couple key questions that we asked on here that have, among all these insights, which are great, there are also a few other questions I really want to point to. One is we asked them, as you can see in the bottom there, if they have urgent needs. Right, really important. So tell us, like, not through your medical provider answering you or some other medical condition, but do you have urgent needs that perhaps aren't medical? On the back, we asked them 2 other questions, and one at the top is, I am very confident, somewhat confident, or not very confident that I can take care of most of my health problems. So again, borrowing or stealing, if you want to use that, from others. One of my colleagues at Dartmouth, several of them who are primary care physicians, have been using that question for about 30 years. And they have tens of thousands of records of patients to know that patients who are lower confident, particularly of lower socioeconomic status, are more likely to be admitted to the hospital and to go to the ED. And we actually, through the data, found that same thing through these questions. And so we took that question because we knew there was evidence. We said, well, let's see if we can learn the same thing here and identify use this as a leading indicator to figure out who might be going to the hospital, who might be going to the ED. And it did turn out that way. We also took stole a question, and adapted a question from Mayo. So in palliative care, there's a question that you're all probably familiar with. But they ask physicians, would you be surprised if this patient died within the next 18 months? We adapted it, stole it, adapted it, and we asked the patient, would you be surprised if you were admitted to the hospital or the ED the next 18 months? this also turned out to be a question that we call a leading indicator for utilization from ED or hospital point of view. They are essentially, a lot of patients are telling us, no, I would not be surprised if I was admitted. We saw significantly those patients were more likely to be admitted to the ED or the hospital. They're telling us. And so then we also wanted to make sure that if we engaged them, we would ask them how they want to learn. And then we did something that we thought was person-centered, that could humanize the conversation a bit. And we asked them to tell us in writing what they liked or to draw something. And we have pages and pages and pages of drawings from patients. So patients in the clinic, we have patients lying in their hospital bed, drawing pictures to tell us what matters most to them. And this gets back to that point of a principle. Why would we include this? Because one of our principles tells us what matters most to you, not just what's the matter with you. And so here's a few examples of work, family, church. We saw plenty of examples of exercise, of food they like, etc., other hobbies. And so we have pages of people drawing what they like. And a lot of those are the primary themes. Again, exercise, hobbies, family, church. Sometimes they would draw money. I want more money. Sometimes they would draw a banana boat, like a ice cream something, right? Very human. And one of the things that, Amy, if you remember, 2 years ago, when I was presenting to a board meeting, and we were talking about this early before we had all these results, but we had these pictures, is, one of the things that Maggie said, he goes, I would love for our encounters to start with, it's not up here now, but there was a picture of somebody drew a truck, and they named their truck or something, with how's your truck? Like what's going on with your truck, right? Not what's going on with your diabetes or whatever else. To really create that sense of, we have a human in front of us, we care about who you are and what matters to you. And we've heard that from patients, how much they do enjoy the time if they do have the time to draw a picture and to share what really matters to them. So it is meaningful. And so those are some of the key insights that we have is one, patients really appreciate the fact that they could take the time before a visit or if they're in the hospital bed, to just express not what some of their medical needs or concerns are, but what some of their social needs are. But one of the things that we found was there were the top three concerns really across the board. Health was a primary one. But either second or third was stress and anxiety. And you saw in here on the card. We just asked, generally, among all these, my anxiety, stress. Well, we know a little bit about that question, right? But what it led us to was, to tell us more. That could open up conversation, tell us more why you have anxiety or stress. So when we put all this data together, we saw a couple things around stress and anxiety, for example, is those patients who marked stress and anxiety were also about 4.2 times more likely to put isolation as a primary concern. It's a really big number. 4.2 times more likely. We're not talking about just 42% more likely or whatever. We're significantly more likely that these people are feeling isolated. Again, not just lonely, right? There's a difference between isolation and lonely, but isolated. We also found a number of other things. Reporting 3 or more concerns was a leading indicator for self-care challenges. And this leading indicator point, I think, is really important for you all to think about, because if you were to employ this in your office, again, you may have only time to deal with medical issues, right? But if you get this card, now it's an Epic and you can see it in Epic, but if some practices are still using the paper card, it's just to see, well, if someone marks stress and anxiety, I might just want to put in a referral. REF 188 is a referral code that you can put into Epic. Our team picks it up. We'll follow up with the patient, tell us why you have stress and anxiety, or tell us why you have an urgent need, whatever, and they'll document everything in Epic. And then you can track them from there if you like, or follow up. That's simple. But this leading indicator point, again, is through the data that we can share with you, is we can tell you who's more likely, if they check this or that, or 3 more concerns, for example, is more likely to be isolated, more likely to show up. This is new data that we can, again, use as leading indicators for decline and for someone who's maybe not optimizing life and needs a little bit of help. We also know, as you all know very, very well, that, and we talked about this, your zip code often determines more of your health than your genetic code. We're seeing that in the data too, right? I mean, we pair all this data at a zip code level, and we also compared it to some economic data that's out there. It's not FirstHealth, it is out there. They call it distressed zip codes, counties. And we see significantly those people who just live in those zip codes themselves are 5.2, say the most distressed zip code in the North Carolina, in our service areas. They're about 5.2 times more likely to go to the ED or have 2 hospitalizations in the past 18 months. Like just by geography, we're seeing them report more, we're seeing the utilization more. The important thing that we are trying to do is to understand, well, okay, you live in that area, but what is your concern that we can address to help you, one, avoid avoidable utilization, ambulatory sensitive utilization, for example, and or get the self-confidence you need to optimize your life and at least address some of your key concerns. Same thing with low confidence. I talked about we're just supporting the data that's already out there around low confidence. And then we just talked about some of the written comments, the things that people are really trying to tell us matter most to them, so we can all have a relationship-based care system. And this is one patient story share with you all. This patient came, and you see down here in the bottom, 17 inpatient, outpatient visits in 18 months. He is a diabetic. And FirstHealth's was never getting paid for his services, for providing care to this patient. The inpatient team was so tired of dealing with him. They were just exhausted, frustrated. They didn't want to see him anymore. And the patient felt it, right? The patient was like, I don't like these people. But he would keep coming back because his condition was uncontrolled. But what we did is we went in, we gave him the card, we built this decision card, we talked to him, and he knew everything he needed to do around his medication management. He knew, he just wasn't doing it. And we spent time with him a little bit, and sometimes this, again, one of the reasons why this is so important, right? Because you all don't have the time to do this relationship. Like, we were able to spend probably 3 months with him, not in effort, but duration, to help coach him to get some self-management skills. And we built a relationship with him. And now he has a job. He's not come back into the hospital, and he's on with his life. Now again, it's a really fun case to highlight, and that all cases aren't going to turn out that way. But this wraparound service to address both, help them get the medical skills that they need, but also the self-confidence to manage their lives and do some things to get on and outside of the medical system when they don't really need our medical team. It's just one example of the type of work we're trying to do, so that you all are and can focus on those patients who truly need your great medical skills to help people be well, get well, et cetera. And so one of the things I haven't touched on yet is we actually were very thoughtful from the beginning as how we were going to measure outcomes, right? Patient care, of course, optimizing well-being. We also set out to say, are we going to make sure that providers appreciate this service, that we're doing the right thing for providers as a wraparound service? We want to make sure that not just outcomes for patients are important, but they are satisfied with our service. But then, importantly, right, if we couldn't prove that we could deliver financially for FirstHealth, then, as we all know, sometimes we all want to do amazing things for patients. We have many ideas, but if we can't sustain it financially, we can't always do those types of things. So we also said we needed to prove ROI, right? And so in this case, we said we're going to do it regardless of payer model. That's the one principle we also wanted to lay out and talk about is we want to provide this service to any patient. On a value-based contract, as we know, optimize quality, take out utilization and spend, you can get your bonus, great. This type of model is clearly much more viable under when you have value-based contracts. We didn't have that opportunity, right? So we need to say, how are we going to make sure that the investment that we made in this can show a financial ROI? So what we focused on is, look, a lot of these patients, like that gentleman we just talked about, and this is why this case was important, we are spending thousands of dollars on this person and not getting paid at all. And taking up a bed and creating frustration among providers, where we could have higher paying people to fill a bed, to generate revenue, and sustain the business. And so a lot of our work ended up being, even though we weren't focused on a payer, we ended up focusing on a lot of self-pay, a lot of Medicaid. Again, self-pay, often we weren't getting paid, or not getting paid at least to cover the service. Medicaid, we know, is a super low margin business. We looked at all of our patients, but we looked at those patients in particular, the Medicaid and self-pay, and we said, for those that we reduced utilization and expenses, how much did that save us in direct costs from analyzing all those patients, from all the work that we spent on them 12 months prior to that time, all the work that was not spent on them 12 months post that time that we engaged them? Did we save direct cost, meaning the amount of money that we would spend on these patients otherwise and lose money on the payment side? Did we save First Health money? And we realized 1,100% ROI. And that's only with Medicaid and self-pay, right? We saved actually more than that with commercial patients in Medicare, but that's also, when you look at a CFO point of view, you're like, well, some of that you're taking revenue out of our system, even though it might be best for the patient. But so we focused on those. We had 1,100% ROI, and the key reason too why that ROI was so high is we only needed about 1.5 people to do all this work. So one of the things that we did, it was about hiring the right person or recruiting the right person. She was already part of the system. Out of the gate, building, testing, building will with providers, and making sure that we had a solid care system first. We hired a person who is a wonderful human being, amazing human being, is a daughter of someone in this room, and we all know and love. But she was 23 at the time, 4, and is so passionate, great with people, and committed to this, and did an incredible, incredible job. And again, hiring the right people with the right mindset, you can train them, build the skills. It doesn't have to be high-cost resources to provide the fantastic support that you all need to really create that whole person care model that optimizes, well-being, not just medical, not just disease, but well-being for people. And the nice thing again is that we proved this over time, and now we have the quality team taking the lead to embed it in all of our practices. Dr. Wilson is making sure we're getting what we need in Epic and has been leading that way. And we're going to figure out over time, how we optimize that experience in Epic. But it's in Epic now, and we have the quality team really making sure that we can institutionalize this. So the other thing that the UNC team didn't talk about is when the last component, right, of change is you do what you need to do to set their direction with clarity, to really state why this is better than it is before. If you build a foundation around the mindset, the culture, you don't just change operational structures. Generate ideas of how this is going to happen. But this last point of what we're at now is you embed the change, right? That's what we're doing right now. The last thing of change, of pretty much a 5-step core process, you embed the change. So we're embedded in Epic. The care team is leading the way to make sure that we can not just do this, say, with a few people, but truly make the whole system work in this whole person way. So we're not there yet, right? We'll learn, but that's the key thing. So I just talked about some of the key success factors and hopefully shared some ideas around leadership and how we can lead change together. And again, not just within the medical system, but really lead in change with our social care partners as well. And we are, like I mentioned, embedding this in Epic processes. We're moving to Hope County next. And we're going to figure out a lot of things, right? Like, how do we work with people in that environment? It's going to be super hard. getting to know new people, establishing MOUs with new social care partners. Hopefully they will be as receptive as they were in Richmond County. And then we have money from the foundation to hire 3 more people to hopefully expand to more Montgomery and perhaps Lee over the next few years. So we're really starting that embed and executing the bigger change so everybody can get access to the service that we talked about. Thank you.